Good afternoon and welcome to our webinar, Preventing Perinatal HIV Transmission, How MCH Professionals Can Help. This program is being provided by the Partnership for Maternal and Child Health of Northern New Jersey. For those who desire nursing credits for the program, we ask that you listen to the whole program. At the end, you will have an opportunity to submit an evaluation form, and once we receive all of the forms, we will send out certificates of attendance by Monday, March 23rd. And now I'd like to introduce your speaker for this hour, Joanne Simone. Joanne is a certified pediatric nurse practitioner who received both her BSN and MSN from Columbia University in New York City. She currently serves as the education specialist at the Francois Xavier Bagnode Center, Rutgers School of Nursing, where her responsibilities include acting as the program officer for the Memorandum of Agreement with the New Jersey Department of Health Division of HIV, STD, and TB Services, reducing perinatal transmission of HIV. She also serves as the principal investigator for assuring comprehensive prevention and treatment for families affected by HIV to eliminate perinatal transmission. Joanne has presented posters and oral presentations focusing on her clinical practice and research at multiple national conferences and has had her work published in AIDS Care, AIDS Patient Care STDs, and HIV Specialists. Joanne, thank you so much for joining us for our program. For the audience, if you have questions, please write them in the chat and we will address as many as we can at the end of Joanne's presentation.
Hello, everyone, and thank you, Amy, for that introduction. And sorry about the technical delay. I'm going to speak to you today about the prevention of perinatal HIV transmission. And there have been some fairly significant developments in the past few years, so I think this will be helpful for those of you who are new to the topic, but also a nice update for those who have been working with women living with HIV. But first, a little housekeeping. There are CE credits available upon completion of this webinar. So I have to disclose I have no conflicts of interest. And in order to receive contact hours for this continuing education program, the registrant must sign in and attend the entire presentation and then submit the evaluation form. And the certificates will be sent by the 23rd. By the end of this presentation, the participants should report self-knowledge gained related to preventing perinatal HIV transmission and intent to change practice by including information or tools presented into professional practice. And the learning objectives are to describe critical interventions for the prevention of perinatal HIV transmission and discuss the role of the community healthcare worker or home visitor in educating patients and families about HIV prevention and care, linking women and infants to healthcare and social services, and supporting ongoing engagement in HIV care for women, infants, and families. Okay. So first, I'd just like to do a very brief overview of HIV, just for anyone who's not completely familiar. So HIV stands for human immunodeficiency virus. It affects specific cells in the immune system called CD4 cells or T cells. And over time, if left untreated, HIV can destroy so many of these cells that the body can't fight off infection and disease. And a little bit about transmission. HIV is spread from one person to another through direct contact with bodily fluids. It is not easily spread. Only certain bodily fluids can transmit HIV, including blood, semen, rectal fluid, vaginal fluid, and breast milk. These bodily fluids must come into contact with a mucous membrane or damaged tissue or be directly injected into your bloodstream in order for transmission to occur. And mucous membranes are found inside the rectum, the vagina, the opening of the penis, and in the mouth. Okay. And how is HIV treated? So HIV is treated using a combination of medicines to fight the infection. This is called antiretroviral therapy, or ART. It isn't a cure, but it can control the virus so that you can live a long, full, healthy life and reduce the risk of transmitting HIV to others. It involves taking a combination of HIV medicines called a regimen every day exactly as prescribed. And these HIV medicines prevent the infection from multiplying or making copies of itself, which reduces the amount of HIV in your body. The less HIV you have in your body gives your immune system a chance to recover and fight off infections and cancers. Even though there is some HIV still left in the body, the immune system is able to retain enough strength to fight off infections. Once the amount of HIV reaches a level that is undetectable, this might be a newer concept for some of the people listening to the webinar. So once the amount of virus that reaches undetectable, then you are no longer at risk for transmitting HIV through sex. And this is called, this concept is called U equals U, or undetectable equals untransmittable. So the goal of any HIV treatment and therapy is to reach this stage of viral suppression. ART is recommended for all people with HIV, regardless of how long they've had the virus or how healthy they are. And if left untreated, HIV will attack the immune system and eventually progress to AIDS. So what do we know about HIV in New Jersey specifically, and more specifically for women? So in New Jersey, there are currently 37,800 people living with HIV. 32% of those are women, and 25% of women living with HIV are of childbearing age. So you can see that we do have an aging epidemic or an aging population, especially among women, which is really a good thing. But it's important to stay up to date and vigilant for our mothers living with HIV. Most women in the state acquired HIV through heterosexual contact, and the vast majority are disproportionately affected women of color. So how is HIV transmitted perinatally? So prenatal or in utero transmission occurs in the maternal transmission to fetus through primary HIV infection, illness, high viral load, or amniocentesis during development. And that's not the majority of how transmissions occur. Most of them occur in the L&D period. So that's when the mother is giving birth, through transfer of blood or other secretions from the mother or infant during delivery, through invasive procedures such as scalp monitoring or forceps delivery, or artificial or prolonged rupture of membranes. And that it really is the time when the infant is most at risk for acquiring HIV. And then some HIV transmissions can occur after birth through breastfeeding, which we will speak more fully about later in the presentation, but also through pre-mastication of foods, which is pre-chewing of food. That is a practice that some cultures do, where the caregiver will pre-chew a food and then provide it to the infant. But this has been shown to transmit HIV, or can transmit HIV, and so people should be counseled against avoiding, counseled to avoid this practice. Okay. So what factors increase the risk of perinatal HIV transmission? You'll see that most of these are related, and the most important one is high viral load. The key to preventing perinatal HIV transmission is to ensure that a mother receives HIV care and is taking her ART medications and achieves a maximally suppressed viral load. The earlier, the better, but certainly before the labor and delivery period. Similarly, identifying acute or new HIV infection in pregnant women is extremely important, because during the acute phase of an HIV infection, viral loads can rise exponentially, sometimes into the millions. And pregnant women specifically are more vulnerable to acquiring HIV due to physiological changes during pregnancy. So extremely high viral loads make it more likely a woman will transmit HIV to her infant. Therefore, knowing the status of your sexual partners and obtaining HIV testing is critical to avoiding new onset HIV, especially during a pregnancy. So with appropriate interventions in the preconception, antepartum, and postpartum periods, perinatal transmission can be reduced to less than 1%. Without any interventions at all, medical interventions, the risk of HIV transmission perinatally is about 25%, or a quarter of infants would acquire HIV. But through these medical interventions, we can reduce the risk to less than 1%. And we have been very successful in this country at preventing perinatal HIV transmission. With the last 2018 cases, with transmission documented in 66 cases reported in 2018. So we continue to work to get that number as low as possible, but some cases do still elude us, even here in New Jersey. So vigilance is key to identifying women most at risk for transmission. So there are several key points in time and interventions to help prevent perinatal transmission, which I will go through now. So the preconception period is really the ideal time to identify women living with HIV who are unaware of their status and optimize the health of all women, including those living with HIV, in preparation for a healthy pregnancy. So I encourage preconception care for your clients, and this includes interconception care or women who are between pregnancies. First, because half of all pregnancies are unintended, and that number may be higher for women living with HIV. And contraception, we know, is underutilized. So it's important for women who do not wish to conceive or are currently unsure about their reproductive plans to access contraception. Second, we know that people living with HIV want to have children just like everyone else, but stigma is still very high in communities. So women may need to be encouraged to discuss their reproductive plans with their provider because they may still be afraid of judgment from the provider. And the goals of preconception care in the context of HIV are to prevent unintended pregnancy, to prevent HIV transmission to partners, to optimize maternal and paternal health, to improve maternal and fetal outcomes, and ultimately to prevent perinatal HIV transmission. So you can begin this conversation just by asking about the person's plans for children in the future. For those who are planning to build a family, discuss the importance of talking with her HIV care provider about those plans. If the woman does not want to be pregnant, then reinforce that contraception is the best way to avoid pregnancy. And I wanted to include this graph because this graphic from CDC, because a lot of times you'll hear people say that people living with HIV should just use condoms. That condoms are kind of a catch-all for contraception, and certainly condoms are important for the prevention of STIs and can be useful for people with partners of unknown HIV status or as part of a HIV prevention strategy with a person who has a detectable viral load. But they are not as effective at preventing pregnancy. And so you can see on this on the graphic that condoms are about as equally effective as using the withdrawal method. And so I think it's important to point that out, that just a general blanket use condoms guidance is really not the way to most effectively prevent pregnancy. So we really want to encourage women to see their provider and choose an effective method that is right for them. And just a note, you'll see that I did X out some of the methods, mostly because they involve all the diaphragm, the sponge, spermicide. They all involve using spermicide. So when you use a diaphragm, you put spermicide, and the sponge has spermicide in it. And the use of spermicide is not recommended for people living with HIV because it can disrupt the mucosal linings and make it more likely for a person to acquire HIV. In addition to HIV-specific preconception care counseling, these topics are also important to discuss with anyone considering pregnancy in the general population, and so should be discussed with women living with HIV as well. And so those are achieving and maintaining a healthy weight and regular exercise, resources to stop smoking and avoid secondhand smoke, and importantly, the recommendation to take your folic acid daily for anyone who's planning to become pregnant to avoid neural tube defects, screening, treatment, management of STIs, which is also very important for the general population, but also very important because STIs can increase the likelihood of HIV transmission, again, because of disruptions in the genital mucosa. Receiving all recommended vaccinations, treating any acute or chronic conditions, and getting them as well managed as possible prior to pregnancy. Of course, referrals and resources for anyone struggling with substance use or mental health issues, and referrals and resources for anyone struggling with intimate partner violence. And another recent and fairly significant change to the perinatal guidelines is regarding safer conception options, especially in the era now that we are of undetectable equals untransmittable. Of course, counseling on safer conception should be performed by an HIV care clinician so that they can assess the person's individual situation and their partner situation to more fully provide guidance to the clients. But I did want to make you aware of the change. The guidelines now say that when the partner living with HIV has achieved an undetectable viral load measured 3 months apart, then there is no risk of transmission during condomless sex for conception. So they used to, or the previous guidelines had stated to only attempt condomless sex for someone who has a suppressed viral load during the period of ovulation, but now they no longer make that specific recommendation when the person is undetectable. But for couples where viral suppression has not been achieved or is inconsistent, or if the partner status is unknown, then of course other prevention methods such as pre-exposure prophylaxis may be offered. And again, timing the condomless sex to ovulation may also be one of the ways that the provider tries to advises clients or patients on safer conception options. And just if you're not aware, PrEP or pre-exposure prophylaxis is a once daily effective medication that people who do not have HIV can take to prevent acquisition of HIV. And it's kind of funny because just a few years ago, my safer conception slides were very long. They used to include not only the timed intercourse during ovulation when the person has a fully suppressed viral load, but before that there was also many other options such as sperm washing or self-insemination for a female who is living with HIV, and IVF. All of these options kind of have been mitigated by the new science that says undetectable equals untransmittable. So in the prenatal period, so once a woman has become pregnant, HIV testing is very important. And HIV testing in pregnancy is prescribed by the state law in New Jersey and is as follows. So in the prenatal period, once a woman is identified as pregnant, universal HIV screening, routine universal HIV screening in the first trimester is recommended, along with repeat testing in the third trimester. And then routine testing in labor and delivery for any woman who comes in to deliver with an unknown status. And if we get through all of those phases and there's still no HIV test on the mother, then postnatal testing of infants whose mother's status is unknown is recommended in order to determine what the maternal status is, because the baby will have antibodies from the mother. Okay. And again, medication adherence and retention in care are really the most important interventions to optimize maternal health and prevent perinatal transmission. So treatment adherence just means that you take your HIV drugs when and how they are prescribed. Treatment adherence is extremely important because it affects how well HIV medications decrease viral load. And of course, the lower the viral load, the healthier the person and the more reduced the risk of transmission. Adherence also helps to prevent drug resistance. So when a dose of your medication is skipped, the virus can take the opportunity to replicate and make more HIV. When someone skips doses, they may develop strains of HIV that are resistant to the medication. And when this happens, it lessens the person's treatment options or available medications that they can take. So we do want to try to avoid resistance to medications through proper adherence. So you want to discuss the management and potential side effects of any of the ARV medications they're taking and kind of have a plan to know what to do if any of the side effects occur. And adherence can be harder when dealing with life changes like substance abuse, alcoholism, unstable housing, mental illness, relationship issues. So if those are identified, really linking to resources and treatment options are important because not only do they affect the person, with the situation that they have, but that's also likely to affect their HIV care and their overall health when it comes to their HIV, treatment. In addition, it is also good to give anticipatory guidance regarding life changes for a woman who's pregnant, to let her know that, the initial postpartum period is very difficult. There are a lot of changes to routine during that time and adjusting to new motherhood. And so that is a time when women are very vulnerable to not adhering to their HIV medications because of all of the kind of chaos that comes around having a new baby. Things that you can do are recommend taking medications around daily routines, same time every day, plan for changes in routine, set automatic reminders or alarms, use a pillbox organizer, and making sure that you watch your supply of medications and order refills on time so that you have time to adjust to any, with our healthcare system, any insurance or paperwork or ADAP requirements that there may be in order to get a refill. Just want to make sure I have. Okay. Okay. Supporting women. Here we go. Prenatal care. There we go. Sorry. I skipped a slide. I think that's what happened. All right, we'll move on. Supporting women who are most vulnerable, who may be struggling with mental health or substance abuse, or who have limited access to healthcare services due to poverty or immigration status, is really another important part of optimizing health outcomes for women living with HIV and their infants. You as home visitors and community health workers can play an important part in identifying client healthcare and social service needs and linking them to needed services. And so FXB also does have a resource guide for healthcare and community services available by county, but many of you also will have identified the resources that you need in your own communities. But just keeping those in mind because, as we said, all of the other socioeconomic and different needs of women living with HIV can really affect their HIV care. So then there's preventing transmission in the labor and delivery period. And as I said before, this is the time period when most transmissions are likely to occur. So there are ways to prevent transmission in this period. So any woman who has a viral load of more than 1,000 copies will be referred for a cesarean section. If the viral load is less than 1,000 copies at the time of delivery, then the woman can deliver vaginally. ART will also be administered during the labor and delivery period, as well as additional intravenous AZT if the woman's viral load is higher than the 1,000 copies. Counseling women to be prepared to share their HIV status when she goes to the hospital. I mean, ideally, the care team will be aware already, but just to let her know that she really should make sure that the staff is aware of her status so that they can do any of the interventions that need to be done to prevent transmission during this period. And ARV prophylaxis will be administered to the infant after delivery, and we'll talk a little bit more about that later in the presentation. In the postpartum period after delivery, breastfeeding is something that mothers will want to discuss. So it actually should be discussed well in advance, and that's what we'll talk about now. So breastfeeding is not recommended for women living in the United States. And that's because maternal ART does reduce but doesn't eliminate the risk of HIV transmission. So transmission from mother to infant has occurred even when the mother was fully virally suppressed. And so that's important to know. So whereas, undetectable equals untransmittable, when talking about sexual contact, it does not apply when talking about breastfeeding. So even if a woman is fully virally suppressed, there have been documented cases of transmission through breastfeeding. The overall rates of breastfeeding transmission are estimated to be at 0.3% after 6 months of breastfeeding and 0.6% after 12 months of breastfeeding. The studies on this aren't great. They were all conducted in low and middle income countries, but that is the best that we have right now in terms of what we estimate transmission risk to be. Another reason that breastfeeding is not recommended for women in the U.S. is because we do have access to safe and affordable infant feeding alternatives that are readily available and accessible in the U.S. And there's not a lot of data on the safety of most modern ART regimens during breastfeeding. So most ARV drugs studied do get into breast milk in varying but low amounts. Serious adverse events associated with ART in breastfeeding mothers appear to be really relatively uncommon. But an infant who does acquire HIV during breastfeeding is at risk of developing drug resistance because they've been receiving lower subtherapeutic levels of ARV drugs during the breastfeeding period, which can promote resistance. So for all those reasons, breastfeeding is not recommended in the United States. And this may be a little difficult for some people because our recommendations in the U.S. differ from those in many other countries where the cost limits access to formula and where inadequate quantities of formula or unsafe water mixed into formula have been associated with high rates of infant mortality. So in some settings where diarrheal disease, pneumonia, and malnutrition are more common, access to clean water may be limited and infant formula may be expensive or inaccessible. Then the World Health Organization recommends exclusive breastfeeding for 6 months and continued breastfeeding for up to 24 months with ongoing ART use by the mother and infant. And in these settings, breastfeeding actually decreases the risks of morbidity and mortality due to pneumonia, malnutrition, diarrhea, which so it's a risk-benefit kind of calculation that each country has to make based on their situation. So for a woman who has lived in a country where the recommendation was to breastfeed, and then now she comes here to the United States and is receiving completely opposite advice, that can be a little, difficult to digest. The guidelines do recognize, though, that women living with HIV may face environmental, social, familial, personal pressures to consider breastfeeding despite the risk of HIV transmission via breast milk. Some of the more common situations that practitioners have occurred are, again, in many immigrant communities where breastfeeding is recommended in their home country, or many immigrant communities even in other countries. The issue that a lot of women have is that if HIV is highly prevalent in your country, then people are more aware of it. So a lot of times people are aware that if you're not breastfeeding, HIV is really one of the only contraindications to breastfeeding. So in essence, if you don't breastfeed your child in the community that expects you to breastfeed your child, you're essentially disclosing your status, not just in your family, but like to your entire community. So a lot of women really do have struggle with that aspect of not breastfeeding. And then another consideration that practitioners have heard is for women who will be delivering in the United States but returning to a country where breastfeeding is recommended. And so trying to figure out what the best way to proceed in that situation will be. Okay. So to better address these social, cultural, emotional issues often underpinned by HIV-related stigma related to breastfeeding, the perinatal guidelines, which is the overarching kind of Bible of how to treat women and infants in the perinatal period living with HIV, has released a patient-centered counseling guide. So they recommend patient-centered counseling that balances the maternal, psychosocial concerns, infant health benefits of breastfeeding, and risks of HIV transmission. They created a guide that you can access, which I'll provide you with the link, called Counseling and Managing Women Living with HIV in the United States Who Desire to Breastfeed, and it's a section in the perinatal guidelines. So they recommend initiating counseling with a non-judgmental inquiry about infant feeding early in pregnancy, and then engaging the mother by offering joint problem solving and shared decision making. So they recommend to say first, in the United States, we recommend formula feeding to avoid the risk of HIV transmission to your baby through breast milk. Do you have any questions or concerns about this? So that you're just kind of opening the dialogue between the mother and her provider, and letting them know that this is something that you can discuss. It's safe to discuss. It's not something that you have to hide if you're having these thoughts, questions, concerns. Because even in the United States, there's a lot of breast is best campaigning, and so a lot of women do need to talk out their concerns and their considerations around not breastfeeding or formula feeding their infants. So if, despite extensive counseling, a woman decides to breastfeed, then harm reduction measures should be taken to reduce the risk of HIV transmission. And again, this is not something that the home visitor or community health worker would discuss with the patient, but these are things that you should know, that if you encounter a woman who is having you should ask your clients how they feel about it. And if you identify a woman who does have concerns or questions, then making sure that you really encourage her to discuss those with her HIV care team, so that she can develop a plan in advance of delivering her baby, so that everyone is on the same page. So in order, if you're going to initiate harm reduction measures, then of course Antiretroviral adherence and engagement in care are kind of mandatory or necessary. Viral suppression is where you would really want the mother to be. In those instances, exclusive breastfeeding is recommended. Exclusive breastfeeding is recommended for the first 6 months. And that's because mixed feeding is really actually creates increased likelihood for HIV transmission during the breastfeeding period. So if you're doing a little formula and a little breastfeeding, the thinking is that the formula can disrupt gut mucosa and allow for easier transmission to occur. So if you are going to breastfeed, then not introducing any formula during the first 6 months is really important. So it would have to be exclusive breastfeeding. Other harm reduction measures, including gradual weaning, not rapid, possibly including extending infant ARV prophylaxis for 6 weeks, or that is the recommendation, infant prophylaxis for 6 weeks. And then other practitioners do sometimes include other drugs or extend the prophylaxis period for longer. It's really a judgment call based on from the provider. So again, this is something that really needs to be discussed with the HIV specialist if a woman is considering it, and the pediatrician as well that's caring for the infant. Then there need to be infant monitoring for acquisition of HIV, because like we said, we don't want the baby to have acquired HIV and then be receiving these subtherapeutic levels of HIV drugs through breastfeeding. And then counseling also on maintaining breast health and prompt identification of any infections in breastfeeding, because once the breast tissue becomes infected or the baby has a breakdown in wounds like a thrush in the mouth, then these also increase the likelihood of HIV transmission. So if you do know a mother with HIV who is struggling with the decision to breastfeed, ensure that she speaks with her HIV care team for complete counseling regarding the risks and treatment options available for HIV. But it can be helpful for her to know that this is something she, should feel free to discuss with her provider. And actually, if she's having these, if she's thinking about it, it is really best to receive the full counseling and know all of the risks and benefits to make a completely informed decision. Okay. Okay. Yes. So some mothers, especially mothers who were diagnosed with HIV during pregnancy, which is very common, they will need additional support in the postpartum period with retention and HIV care. And this is because sometimes women are cared for by OBGYN HIV specialists during pregnancy, but then they'll need to change providers completely postpartum to someone new, someone they've never seen before. And so ensuring that women are able to make the transition to their new care team is definitely important to provide continuity of care and maintain women on ARV therapy. So just keeping in mind that the postpartum period can be, a time when a lot of women can drop out of care for a multitude of reasons, but that being one of them. In addition to HIV care, a new mother will also need to attend her postpartum follow-up appointment. And we know that many women do not attend this appointment, but it's so key to ensure that the woman is recovering from the birth process. And also, it's an important time to talk about pregnancy prevention in order to space pregnancies. And in addition, this is not in the postpartum visit, which is usually 6 weeks after, but in the hospital postpartum, the new perinatal guidelines do specify, and this is kind of new, that for women with no medical contraindications, then a single dose of cabergoline postpartum can inhibit lactation if given the first day postpartum. So this is just a bit of anticipatory guidance that you can give to your patients, that this medication does exist so that they can actually inhibit milk from production from occurring instead of having to go through the process of suppressing milk production in the postpartum period because women are recommended to formula feed their babies. Okay. And a new mother also needs to be linked or retained with any other health care or social services that she may need. So making sure that those are occurring is also very important because, like we said, a lot of other things can affect whether a woman is able to really participate in her HIV care. Also, women often get a lot of breastfeeding support and guidance in the hospital setting. But for women who are formula feeding, it's not always an intuitive process, especially for immigrant women where breastfeeding is not the norm, where breastfeeding is the norm in their culture. They won't have a lot of experience, with formula and preparation. So just ensuring if you're visiting a new mother that she understands how to prepare formula, how to use the correct proportions of formula to water, and not to reuse formula. And also, again, that mixing breastfeeds and formula feeds for women with HIV increases the risk of transmission through breastfeeding. So, some women may have the idea that, when their mother-in-law comes over, they can put on a show of breastfeeding for them, but otherwise formula feed. But just letting people know that this, that mixed feeding is really not recommended. Okay. So the final, step in preventing perinatal transmission is the infant's care. So providing infants with prophylactic medications in order to prevent HIV transmission is a key intervention. So all infants will be discharged from the hospital on some kind of regimen that is dependent on their risk of transmission. So for infants whose mothers were virally suppressed, they will receive 4 weeks of AZT. But for mothers in other high-risk scenarios, the pediatrician specialist will determine if the infant will benefit from either a 2-drug regimen or sometimes in a particularly high-risk situation, then they will start empiric HIV combination therapy on the infant until their status is able to be determined. But every infant will have some kind of prophylaxis in the newborn period. So you should just know to ask mothers about how that's going for them. So asking them if they, making sure that they can access the necessary prophylactic medications for the baby, that they're educated about the dosing and administration, if they have any barriers to providing the prophylaxis, so any knowledge gaps or beliefs, any limitations or issues around disclosure. Sometimes it is hard, a lot of people will ask you why you're giving your baby medicine so soon. So just enabling people to kind of have a response for that if they don't, want to disclose to a family member coming to visit the baby, and having an active linkage to an HIV clinician for infant follow-up. So that should be established, and this is important too because if the regular newborn care from a pediatric provider on a regular schedule. So infant will see an HIV specialist for care at approximately 2 weeks, 1 month, 4 months, and then possibly 12 to 18 months. It's not highly used anymore, but some practitioners do still for HIV testing and assessment. But that is a specialist appointment. The newborn is still to attend their regular newborn care with their pediatrician. So, because that's where they'll be receiving their infant, their newborn assessments, their vaccinations. So that can be confusing for some people, that they really should be seeing their HIV specialist, but also their regular pediatrician, and just making sure that that's occurring. So if you're interested in any resources, the FXB Center does have resources for both healthcare providers and clients, and we can make them available. You would just have to contact me after the webinar, and we'll be sure to get them to you. And that is all the slides I have. So I have some time for questions if there's any in the chat box.
Thank you so much, Joanne, for that presentation. While we're right now, we're not seeing any questions at this point. Oh, here comes something. I knew when I said that that would happen. How long does it take to get the results from HIV testing?
So, so you can't get, well, so you can't get a definitive negative result until at least four months. So they will do the HIV testing. That's why they do it at 1 month, 2 weeks, and 4 months. If all of those tests come back at 4 months, you can say that by 4 months you can say that the baby does not have HIV. If the baby does have HIV, all you need is two positive viral loads, just taken in two separate specimens. So that can be done relatively quickly.
And how about for the adult who's tested for HIV? How long does that take to get results?
So it depends how it's done. There are point of care tests for HIV, so people can learn pretty much on site if they have HIV. Otherwise, it's just a standard test. If they send it to LabCorp or wherever your testing service is, it'll come back in a day, 2 days, 3 days, however long it takes them to send it out and print the report. But it should be fairly quick.
Great. Why does the transmission rate during breastfeeding increase between 6 and 12 months?
It's just the extended time period. So the exposure is longer. So you've had a longer time to be exposed to breast milk that may transmit HIV, and that's why the transmission rate goes up over time.
Thank you. What do you mean when you say new mothers should not reuse formula?
Oh, just like if you feed it to the baby and then put it down or put it in the refrigerator, you can't go back to it once the baby's drank the formula. You have to use it like within an hour, I think they say. Otherwise, it needs to be disposed of.
Okay. And are there any special needs that need to be addressed of a teenager who's living with HIV and pregnant?
Yeah, well, yes. I think any teenager who is pregnant definitely has special needs, special requirements. Teenagers are notoriously not adherent with their medications, so they would need that support. And teenagers who were perinatally infected or who acquired HIV during the perinatal period also have some unique, considerations when it comes to having a baby. So, I mean, yes, I think teenagers in general just would need more support, more family support, and more support for adherence, and everything that goes along with a teenage, pregnancy.
Thank you. So I have one request about the link to the Counseling and Managing Pregnant Women with HIV guide.
Mm-hmm.
Is that something folks should reach out to you for that link?
I don't know if you're going to send anything out, but I can send it to you very quickly. It's the perinatal guidelines link, and those are it's very quick for me to access, so I can send it out to everyone. No problem.
Okay, great. We can take care of that.
Yeah. And that's, I'm sorry, I just want to, so the counseling guide is housed within those guidelines. The guidelines, like I said, are comprehensive. So they're hundreds of pages long. And again, they cover like from preconception through postpartum and infant care, everything a clinician would need to know about managing a woman and her infant living with HIV.
Sounds like a great resource.
No, it really, yeah. And sorry, the same link or there's guidelines in there. There's the perinatal guidelines, but there's also the adult and adolescent care guidelines. There's pediatric guidelines for any children living with HIV. So they make several different guidelines, and they're all extremely comprehensive.
And it's all online.
Yes, yeah. It's on the website is called AIDS Info, but it's through the National Institutes of Health that put together the panel.
So if people Google National Institutes of Health,
if they Google perinatal guidelines, really it'll come up. It's got a very long technical name, but that's kind of how people just refer to them.
okay.
They should come up. But again, I will send the link so that you have the correct ones.
Excellent, thank you. We have a few minutes left. Did you want to talk a little bit about the work at FXB, just to give people any additional time to type in questions?
Yeah, sure. So the FXB Center started actually the first cases of perinatal transmission were actually discovered in Newark, which is something many people don't know. So they were perinatal transmission was first identified in Newark, and so the FXB clinic was one of the first clinics that cared for the infants of mothers who had HIV, and many of these children did end up having HIV because, like we said, there's a 25% risk if nothing is done. And so when initially HIV was being discovered and that perinatal transmission was possible, there were a lot more children who did acquire HIV through perinatal transmission. So the FXB clinic was started to care for those children. And since then, there's still a clinical component to our center, but then we've also grown to do a lot of education and training around HIV care in many different arenas. So right now, we do have a small perinatal program still for education and training. We also have the AETC is the AIDS Education and Training Resource, the AIDS Education and Training Center. We house the National Resource Center for all of the healthcare educators who work through that training system. And they're available to give training to all healthcare workers on many topics related to HIV. We also have a pretty large program through the Division of the Division of Child, permanency.
DCP&P?
Yes, but what does it stand for? I'm blanking on the.
That's okay. We could just use the acronym.
For Child Protection and Permanency. Thank you.
Okay.
For the Division of Child Protection and Permanency. Children who are placed into the foster care system who have medical needs are provided with a nurse to case manage their health care and clinical needs while they're in the foster care system. So we have several different kind of arenas that we work out of, all of which though originated though with our our original purpose, which was related to perinatal HIV prevention.
Great. Well, thank you so much. It looks like our listeners don't have any more questions. So thank you for this wonderful presentation. Again, for those who are on the webinar, we would love to hear from all of you as far as the survey goes, but certainly if you are looking to receive credits, please be sure to fill out that survey. And I'd also like to mention that the partnership will be broadcasting webinars throughout the coming weeks. And so for those of you who already receive our emails, please look for those. If you're not on our mailing list, please reach out to me. I'm Amy Gohl. I'm the Director of Education for the partnership. And you can email me at agohl, G-O-L-E, at partnershipmch.org, and I would be happy to add you to our list so you can hear about our future webinars. Thank you again, Joanne. Thank you to Monica Smith, who has been doing all the background work and got us up and going online. And I want to thank everybody who participated in this webinar. Thank you.